Hello, my name is Dr. Ken Rosenfield. I'm an interventional cardiologist and head of the section of vascular medicine and intervention at Mass General Hospital. And we're here today, myself and my colleagues, on behalf of Jupiter Endovascular. I'd like to introduce my esteemed colleagues who are all amazing interventionalists who practice actively and are experts in pulmonary embolism treatment and management. I'll start to my left with Dr. Sripal Bangalore, who's a professor of medicine and director of invasive and interventional cardiology at Bellevue Hospital at NYU in New York City. Welcome. And to his left is Dr. Vikas Aggarwal, who's an interventional cardiologist and expert in PE and also in the long-term consequence of PE, CTEPH. And he's at Henry Ford Hospital in Detroit. And to his left is Dr. Catalin Toma, who is a interventional cardiologist and director of interventional cardiology at UPMC in Pittsburgh. So welcome all. It's exciting to have you here. This is a very exciting time to be involved in pulmonary embolism management. There's new guidelines, there's new evidence coming out on almost a daily or monthly basis at least, and a lot more evidence to suggest that hemodynamics should play a role in decision-making about pulmonary embolism and how we manage and how we make decisions about patients and also how we evaluate outcomes. So we're going to go into this in more detail. We have three separate presentations that all will address some aspects of this. Looking forward to this discussion on each of these topics and also broad-ranging discussion afterwards. So with that, I'm going to start with Sripal, and maybe you could talk to us about hemodynamically guided pulmonary embolism management in the current era, and has that evolved, and what is the role of hemodynamics in making decisions?
Absolutely. First of all, I think I'm glad we are talking about this. I mean, you're absolutely right that now is the golden era of management of PE. So I'm going to give a brief insights into hemodynamics and how we use in the management of patients with PE. So we'll start with the case. So this is a patient we saw a couple of months ago. So 65-year-old female, multiple risk factors, and her story started 2 months prior. She was having a lot of back pain, spine issues. She underwent posterior decompression and fusion of her spine. So interestingly, post-surgery, she continued to have symptoms. She was having leg paresthesias. She was using a walker. So she wasn't as mobile as we would have wanted her to be. And she presented for the past week with exertional dyspnea, orthopnea, and interestingly, multiple syncopal episodes. She was brought in by her daughter saying she has syncopized multiple times. And when she presented, you can see her blood pressure was stable, 114. She was a bit tachycardic to 102, and she was satting 94% on room air. And of course, in the ER, an EKG was done. Nothing striking in terms of the EKG, but a quick set of labs which were drawn. Markedly elevated D dimer. Her pro-BNP was significantly elevated. Her troponin was positive. Her lactate was negative, it was 0.8. And clearly, given her history of recent surgery and her presentation with a markedly elevated D dimer, PE was suspected. This was an echo which was done. What is impressive here is left ventricular EF is normal. Our RV is clearly dilated. It has hypokinetic as the classic McConnell sign, but you can also see is a clot in transit. So you have this big clot bobbing in and out of the RA, ready to embolize. And of course, she also got a CTPE. So here you can see with the CTPE, she has right and left main pulmonary artery thrombus extending to all lobes, and she also has right heart strain. And this is an axial view of the same thing where you can see clots in both the pulmonary arteries, and lower down you can see that she does have a right heart strain with the RV being larger than that of LV. So just to summarize her, so she presents to us with a recurrent syncope. She has a large PE burden, including clot in transit. She has a increased RV-LV ratio. But hemodynamic-wise, she's only tachycardic to 100, but blood pressure she's maintaining. She has positive biomarkers, negative lactate. We typically work these patients up with a bedside DVT scan, and the DVT scan did show that she did have left common femoral, popliteal, peroneal, posterior tibial vein DVTs. There was also some residual DVT in her right leg. What we did in our case was to take her for thrombectomy. So here we are going after the clot in transit in the right atrium. So one aspiration, we were able to take this clot out from the right atrium. And what we do for all of our cases is first to get hemodynamics before we go after the PE part of it. So these are some of our hemodynamics. So we do a right heart cath. So our systemic blood pressure was 108/55. RA pressure mean was around 12. The PA pressure was 64/21. And we do cardiac index, this is by FIC. Our cardiac index was extremely low, it was 1.4. Despite the fact that our blood pressure seemingly looks stable, she was satting 98% on 4 liters, and we do a blood gas there, and on 4 liters, our PaO2 was 79. And what is impressive is, we do these cases, we also have an A-line, and what I want to emphasize to people is, with the A-line, not just to look at systolic and diastolic pressure and be comfortable with it. And, I tell my fellows, look at this A-line, there is a story it's trying to tell us. And what we see here is, this patient is breathing normally, we're not asking her to take deep breaths, etc. So normal respiration, but you can see the systolic pressure varies from around 120 systolic down to around 20. So this is the definition of pulsus paradoxus. So she does have pulsus paradoxus on her A-line. I mean, at this point of time, we only have a pigtail catheter in her pulmonary artery, and we're checking her A-line. If you follow some of the other beats, I mean, the variation is as much as 30 millimeters of mercury. Here, after 2 minutes, you can see some more of the blood pressure recordings here. This is more of a pulsus alternans with blood pressure higher and lower. And what is impressive is if you look at some of these heartbeats, the pulse pressure is very, very narrow. The blood pressure is also very narrow. And I think this is very important. So whenever I see this, I'm very concerned. I'm sure many of us who do pulmonary thrombectomy have noticed this. Many a times, if when you're passing in your large bore catheter, the pain itself, sometimes the patients will Valsalva, and you can see the blood pressure will plummet down. So many a times it's going down to 40. So I think, this kind of emphasizes the importance of, being cognizant about hemodynamics. So here is a patient where I'm seeing pulsus paradoxus, pulsus alternans, and the cardiac index is very low at 1.4. The question is, could I have predicted this because her systolic pressure is okay? It's important to emphasize that the 2026 ACC guidelines recognizes this, and it's categorized as a category D2, which is normotensive shock. And you can see here on the classification that when you reach C and D, and especially D and E, you're already in a higher risk category, and this is D2, which means the patient is in normotensive shock. So the guidelines would say it's a class 2A indication in hemodynamically stable patients diagnosed with acute PE and who are in category C and D to use a validated PE specific risk score. And they do emphasize that one of the scores that I was involved in deriving and validating called CPES should be considered for further risk stratification of these patients. So what is the incidence of normotensive shock in intermediate risk patients? It's around a third. So 1 in 3 patients who are hemodynamically stable are in normotensive shock. So in other words, their cardiac index is less than or equal to 2.2 despite the fact that the blood pressure is stable. So all of these patients are compensating by increasing the peripheral vascular resistance, and that's why you can see that the blood pressure remains stable. We derived and validated a score called the CPES score. This is now part of the guidelines, and the components of the CPES score includes a marker of clot burden in the pulmonary arteries. So first question you ask is, do you have central clot or a saddle PE? Second question to ask is that clot causing a strain on the right side of your heart? That strain is measured by 3 parameters. Do you have elevated troponin, elevated BNP? Do you have moderate or severely reduced RV function? So you get 1 point for each of this. Is there anything else that can make the situation worse? And that is determined by, does the patient have concomitant DVT? And the last question to ask is the patient currently compensating by being tachycardic? So 1 point for each. It's a total of 6 points. The higher the number of points, what we showed was greater is your incidence of being in normotensive shock. So there are a number of risk scores, and the guidelines attest to this. CPES is one of them. you have the SPECI, you also have the BOVA, we also have NEWS score. Recently, we compared many of this. So if you look at CPES score, in this particular patient, the CPES score will be 0, but if you were to use SPECI score, because of her age and other comorbidities, she'll be categorized as high risk. But SPECI, for example, I give an example of an 82-year-old female with UTI who has a subsegmental PE. SPECI will say she is high risk, but we know the subsegmental PE has no bearing on her presentation. The CPES will say it's 0 because she has no PE-specific risk factors. CPES is the only hemodynamic and PE-specific risk score, and we actually compared other risk scores, and we showed both for primary composite endpoint and PE-related mortality, CPES outperforms other risk scores in predicting PE-related outcomes. And it can potentially guide treatment. So we use a cutoff of 3 or greater to say which patients needs to go for thrombectomy. And we showed that using that cutoff, I mean, this is observational and retrospective, where we showed that there is significant benefit of mechanical thrombectomy in patients who have a high CPES score. So let's go to her. Her CPES score was 6, so that means her risk of normotensive shock is 58 to 100%. Her risk of death is 40%, cardiac arrest is 40%, hemodynamic deterioration is 40%. So we saw this hemodynamics, and I showed you the pulsus paradoxus and also pulsus alternans. What did we do for her? We took a therapeutic time pause. So what we did here was we said, let's not introduce a large bore catheter because our hemodynamics are labile. So we gave IV fluids and dobutamine for 10 minutes. And here, right off the bat, you can see our hemodynamics are much better. So the pulsus paradoxus is much better. The variation is less than 10 millimeters of mercury. We went ahead and did mechanical aspiration thrombectomy. This is first aspiration. Immediately after first aspiration, you can see our blood pressure is much, much better. The pulsus paradoxus is much improved. This is, we went after more clot, cleared up the right lower, right upper, and this is the final angiogram. Again, we did the same thing on the right side, left side. There was a ton of clot. We were able to do mechanical thrombectomy of all of these. And you can see hemodynamics after final aspiration. Now our blood pressure is in the 180s. Pulsus paradoxus is gone, pulsus alternans is gone. She did pretty good. This is the amount of clot we got from her. And what is impressive is we did repeat hemodynamics at the end of the procedure. Cardiac index jumped from 1.4 to 4.2. And you can see all the other parameters also significantly got better. Our echo, 36 hours later, you can see that RV is much better. So it's doing much better, significant improvement in our RV function. So the key take home from this example, I must say though, she came in, a traditional definition of being stable. Our blood pressure was in the hundreds, etc. But clearly, our hemodynamics, when you actually measure hemodynamics, she was in a state of normotensive shock. She had pulsus paradoxus and alternans. We stabilized her briefly. We took 10 minutes there, and then post-thrombectomy, we see significant better hemodynamics. So I want to emphasize that the hemodynamics are key to pre-procedural and inter-procedural decision making.
Well, that's a fantastic case. Really amazing outcome, and it does demonstrate the value of the CPES score in a patient who's got normotensive shock. Procedurally, do you think about that in advance when you have a high CPES score like that, 6? Do you approach the patient differently? Are they, though they look okay, I mean, the patient looks fine, although her index is 1.4 and she's got all these terrible parameters hemodynamically, do you worry a little bit more about introducing a 24 French catheter, for example, or how you manage them? Is there some other way you approach them? I noticed you gave dobutamine. Is there anything else you think about in advance?
Yeah, no, I think that's a great question. So what we do is we use CPES before they go to the lab. And you're absolutely right. If the CPES is high, I'm worried, regardless of what they say. Many a times our pulmonary guys will say, she's lying on the table, she's doing okay, the blood pressure is okay, but I'm like, that CPES is high, she's likely in normotensive shock. But in the lab, we base it purely on complete hemodynamics, including their cardiac index. And I do worry if the index is less than 1.5. Again, these are all, we need more evidence to it, but my practice is if it is less than 1.5, we pause and we feel like we need to do something, make sure if you think that the patient is imminent to crash, also make sure that your ECMO facility is available. And so on.
Good, great point. You guys have any other questions? Any questions or comments about this kind of a case? Would you do something differently?
First of all, I would like to commend you for an amazing presentation and a case that highlights how hemodynamics is what matters most when it comes to taking care of these acutely ill patients, and setting yourself up for success, I think, is the key. Optimizing that patient, studying that patient, evaluating and getting to the right answer as to how I'm going to safely get this patient from point A to point B. So be it stabilizing them with an inotrope or a vasopressor or mechanical circulatory support, and then making sure we follow them afterwards and making sure they continue to do well is also very important.
Yeah, Catalin, this really underscores how pulmonary embolism is a hemodynamic issue. It's not a lung issue. I remember when I started doing this stuff, I thought, oh, it's a lung issue. No, it's a heart issue. And, setting yourself up, as Vikas said, setting yourself up for success is important.
I mean, this is clearly treating cardiogenic shock, and you have to have not just the anatomical component of treating it, which is the afterload, component that you're going to treat with aspirating clot, but also the preload, the IV fluids, and the RV function, which can be easily supported with inotropes. One thing that we don't realize, and we're so afraid of using inotropes, is because we parallel this to LV shock, where the patient is ischemic, where inotropes can be detrimental. It's a different story on the RV side. The RV would love a bit of epinephrine and dobutamine temporarily to bridge through the procedure, so it's perfectly fine. That doesn't mean you made the patient worse. That's something that will help you go through the procedure successfully.
I think those are great take-home messages. The reality is, I think many people just jump right into these cases, and they don't realize that the patient's actually in normotensive shock. And that is an issue that we all need to educate our colleagues about. Well, that having been said, let's move on to Vikas and have you discuss the issue of persistent elevation in PA systolic pressure. By the way, I noticed that the PA pressure in this patient remained at 65, even though systolic, even though you'd actually removed all that clot, but the cardiac output was triple.
Right.
So,
and interesting to that point, if you see your pressures, the systemic pressure increased by 80-folds.
yes.
80 millimeters of mercury. So, we still haven't figured out how do you correct for that significant increase in our systolic pressures. I bet if you bring our systolic pressure back to 108 when she started, our pulmonary pressure is now 40.
You're probably right. So how measuring outcomes is something that we're just learning more and more about. I think the new guidelines help us, but we need to develop that evidence base even more. So let's move to Vikas, who's going to talk to us about pulmonary artery pressures that are persistently elevated after you do pulmonary thrombectomy and even extending into follow-up.